everyone.
Good evening.
Good evening.
Can I
Good
welcome
evening.
you all to the virtual Health and Social Care Scrutiny Subcommittee meeting? Present are members and advisors of the subcommittee, council officers, partners, organizations, and portfolio holder for adults and public health. Can I refer members and officers to the published protocols for holding virtual meetings? Please note the following. Members of the subcommittee should ensure they have their videos on at all times, but put the microphones on mute unless speaking. Other members and officers should switch off their videos and put the microphones on mute until they are invited to speak. In case of a technical problem, the meeting will be adjourned until the issue is resolved. If the technical problem persists and the meeting is incorrect, the meeting will be abandoned and rearranged for a later date. The meeting is being audio and video recorded and will be available to watch, listen to on the website. Okay, everyone, okay? Can I start the meeting? The main agenda now. Notification of replacement of a councillor on the subcommittee. Item 1. Can the subcommittee note the replacement of Councillor Natasha Proctor by Councillor Karima Marikar as the main member of the Health and Social Care Scrutiny Subcommittee? On behalf of the subcommittee, I welcome Councillor Marikar and thank Councillor Proctor for their contribution to the work of the subcommittee. Item 2, attendance by reserve members. There are none. Item 3, declarations of interest. The declarations of interest have been published on the council's website and will be taken as read. Do other members of committee have any more declaration of interest?
Can I just say that at the moment, looking at the agenda, I don't have anything to declare. But while going through the meeting, if I think I have to declare, if anything to do with Public Health England, then I'll declare my interest.
Okay.
I can think Carol there.
Thank you. Anyone else?
Yes, I have to declare because I do work for the two trusts, Hertfordshire and CNWL. So I do have a pecuniary interest, isn't it?
Okay.
Thank you.
Chair?
Yes.
I don't know if this counts, but I've had recent contact with Health Watch on 2 issues, which are not really being dealt with this evening, though.
Okay, that's fine. Thank you. Okay. Minutes of the last meeting. Can we approve the minutes of the meeting held on 23rd of February 2021?
Approved.
Thank you. Now, item 5 is appointment of vice chair. Please, can I have nomination for the position of vice chair? Sorry, Councillor Leslie Levinson, are you going to propose vice chair's position? Veena?
Veena, yes, I do.
Yes. Can you speak, please? Can you speak? That you would like to nominate Veena?
I would like to nominate Councillor Veena Matani.
Okay. Have you got a seconder? Michael, can you second it?
Happy to second it.
Okay. Thank you. So Councillor Veena Matani has been appointed as the vice chair of this subcommittee for this year. Appointment of non-voting. Thank you. Appointment of non-voting advisor to the subcommittee. This is on item 6. The 2 members I have here is Dr. Nizam Mirali and Mr. Julian Moore, Health Watch Harrow. Ms. Nizam Mirali is local medical committee. So that's accepted, yeah?
Yes.
So I appointed those 2. Thank you. So public questions. No public questions have been received. Item 8 is petitions. Are there any petitions? No, we haven't received any. 9 references from council and other committee panels. There are no references. Now, item 10, COVID and vaccination update for Harrow. Would Paul Hewitt, Corporate Director of People, introduce the presentation? Thank you.
Okay, so our Director for Public Health, Carol Furlong, is going to do a presentation on the current position with regard to COVID, and it will be combined with information on the vaccination programme, and other officers and partners will contribute as we go through the presentation.
Thank you.
I'm just trying to share my screen, sorry.
Thank you, Carol. Welcome.
There we go. Right. Okay. So I'm going to give an update on the epidemiology of COVID in Harrow, and talk a little bit about screening. I'll touch on vaccination, but Lisa will give you a better update on vaccination. So before I start, I just wanted to, I've been missing my Swiss cheese slide because I haven't been showing it for the last few meetings. So, sorry. So I just wanted to remind people that there are lots of things that we do to try and protect ourselves and our communities from COVID. And that ranges from physical distancing and staying home if we're sick, our hand hygiene, masks, and avoiding touching your face and not going to crowded places. Ventilations are opening the windows if you're in an indoor space. Getting tested if you've got symptoms, and getting tested if you haven't got symptoms. Quarantine and isolation, and of course vaccination. And all of these things, when you add them all up, they stop COVID getting all the way through. Nothing is 100%, so no single thing will protect us all from COVID, but the more things we do, the more chance we have of not getting an infection and to reducing the infection within the borough. And it's up to all of our responsibilities to make sure that we do that. So if I move on to the dashboard. So this is the dashboard that I've presented before, and it shows here that at the moment Harrow has 52.6 cases per 100,000 population. That's 132 cases that we've had in the 7 days up to the 17th of June. And that was an increase on the previous 7 days of 65%. So it's a significant increase and a big concern. So you can see that in the graph at the bottom, the rate has been going up and is continuing to grow. We saw a slight decrease. It was a matter of 1 or 2 cases yesterday. But overall, if we look at some of the interim data that we've had through our notifications, we've had 156 notifications in 7 days up to the 21st. So that suggests that the rates are going to climb again tomorrow and for the next few days, at least. The rates in older people have risen a little bit, but we've only had 7 cases in the last 7 days. But that was a big increase on only 3 cases the week before. So that, you know, we are seeing increasing cases. Our positivity rate has also gone up, and that's 1.8 at the moment, which is the highest that it's been in quite a while, over a month, no, 2 months, I think, of the numbers of people getting tested has risen a little bit, but not significantly. This big peak here on the graph and the big dip there was when we did some surge testing in schools in Harrow, because we had a number of cases of the Delta variant that we were concerned about that was happening in younger people. Since that point, the number of cases of the Delta variant has increased, and now the vast majority of cases are in younger people. Oh, sorry, vast majority of cases are of the Delta variant. If we look at it geographically, there isn't a really great pattern. It's not consistently in any particular ward. It's not consistently in any particular area in the borough, and it fluctuates from week to week. So in the 7 days to the 12th, the highest rate was in Hatch End and West Harrow, but last week you can see it was in Queensbury. So there's no consistency in that. It moves around quite a lot. And what we're seeing is that a number of the cases are in family groups, so that when one person in the family gets it, everybody in the family gets it, and then that particular ward pops up as being a higher rate. The next week, when they've all recovered, the rate goes back down again. So, so we're not really seeing that huge clusters in particular areas. We do look at all of our data, and this is something that I don't think that we've shown you before. This is our testing dashboard. So we gather all the data from all the different sources and all the different types of tests that are happening. So you'll see on this pie chart, the vast majority of tests that happen within the borough are the lateral flow tests, as you might imagine. They're the asymptomatic tests, and they happen weekly in care homes for NHS staff and for children in school staff, as well as the general public being advised to do them twice a week. So it's no surprise that that's the highest rate. And then we have these, which, although they come out as it says null, these are the ones that are the lateral flow tests. And then there's particular types of lateral flow tests, which is these little tiny ones here. And it varies across the boroughs, and every time we do this graph again, we try and combine 2 weeks worth of data so that we can see whether or not there's any pattern. But every time we do this data, again, the pattern is slightly different. We do tend to have a lower testing rate in this sort of south east corner of the borough compared to the rest, but the rest of the borough sort of chops and changes between being slightly higher and slightly lower. Just to say that all of those lateral flow tests, if any of them turn out to be positive, they get followed up with a PCR test. So there may be a little bit of double counting here, because this is looking at the number of tests that are done. So those people who are positive will have a second test. And this is where our positive rates are at the moment. So in the last 2 weeks, up here, Harrow Weald, sort of Hatch End, Headstone there. This is top part of Harrow on the Hill, and over here in Kenton. So that's where our highest rates are. But nowhere is particularly high, as we've seen in the other data. Of all of our cases, we did have 7 cases that are put down as Harrow cases, because that's where the address of the person is. But they were taken in people who travelled within well, the cases in the last 2 weeks are people who had travelled previously, and 5 of those cases are not actually resident within the borough at the moment. They're being managed in a quarantine hotel outside of the borough because they've come from a red area. If we look at the data in a bit more detail and we look at it by age, you can see that the highest number of cases over here was in the 20 to 29-year-olds, followed by the 10 to 19-year-olds. But if we drill down a little bit more into that data, we can see that it's really here, the 17 to 18-year-olds and the 19 to 24-year-olds, where the majority of our cases are happening. Now, at the moment, well, up until last week, that they were groups that weren't eligible for vaccination. So they now are eligible. So we hope that these numbers will start coming down as more and more of them will get vaccinated in the next 5 or 6 weeks. We are seeing an increase in children in secondary schools and a slight increase in primary schools. But as I said, once somebody in the household gets COVID, nearly everybody else in the household gets it as well. And so those numbers are usually the younger siblings of an older child or somebody in their early 20s. What we are seeing up here is this protective effect of the vaccine. So in the over 60s, it's very, very low numbers, very low rates. We are seeing even in the 25 to 59, it's actually a relatively low rate. So it's really being driven by those young people in the 17 to 24 age group. I wanted to talk about the community asymptomatic testing because that's one of the things that's changing. So what hasn't changed is the offer for symptomatic testing. We still have the mobile unit going to Civic Centre. It goes 3 times a week to Civic Centre, usually Monday, Wednesday and Friday. And then every day we have the 3 local testing centres on Northolt Road near South Harrow Police Station, on Box Tree Lane at the top of Box Tree Park, and in Kenton Rec. So those 3 centres are still open, and they're still open for anybody who has symptoms of COVID. And you can book those online or through NHS 111. But the asymptomatic testing that we've been doing is going to have to change. So our plan for asymptomatic testing is that we want to increase it in those people who are disproportionately impacted by COVID or underserved by testing at the moment. And we want to innovate. We want to look at different ways of actually getting testing out there so that we test people who have not previously been tested and make it a bit more routine across the community. So we're working with the voluntary and community sector to reach some of those people who are not getting tested at the moment. We want to break chains of transmission and try and reduce the prevalence and transmission in those hard to reach groups. We also need to demonstrate that we're doing it in good value for money. And at the moment, our community testing is very expensive because we're renting shop space in a shopping centre and also renting space in the Harrow Arts Centre. So that makes it quite an expensive venture. And Department of Health have now changed the plans for how the funding is going to be distributed, and they've capped the level of funding that's available. So we've had to change our plans and look quite critically, because the numbers of people that have been coming through, as people have been doing more home testing and businesses have been eligible to do testing. When we set it up, businesses weren't included, not all the schools were included. There was no option of doing home testing. So we set it up with the intention of being the main place that people were going to get their asymptomatic testing, and that isn't the case, and it hasn't been the case really probably since Christmas when we originally set it up. So our standard testing offer at the moment is the pharmacy collect offer. This is a national standard offer, so you can collect testing kits from any pharmacy. You can order them online to get delivered to your home, and schools will also distribute testing kits. What we're looking at is our local supervised testing offer. We will be closing the St Anne's Shopping Centre unit, and we will be closing the Harrow Arts Centre unit. We'll be moving the St Anne's unit into the pavilion at Greenhill Library, and that will be a small testing centre there. The Civic Centre, there will be a small testing centre there, but I think it will move from buildings 5 and 6 into the main Civic Centre. There will remain a small offer at the council depot for the staff that work there, and there will be supervised testing in the 15 pharmacies that we've got on board at the moment, and others if they want to come on board. We'll also then offer mobile pop-ups so that we can go around the borough looking at those areas that I showed you that consistently have lower rates of testing. And that tends to be South Harrow, the town centre, Wheelstone Corridor, and the Edgware Burnt Oak area. And within those areas, we've got some housing estates. And so we focus there, because when we look really down at in the details, they have quite low rates of testing. The other features that we have in those areas are houses of multiple occupation, and particular Black and minority ethnic communities, and the rates in some of those communities is quite low. And there's some resistance at doing routine testing. We'd also look at working with faith groups, with people with disability, because we did some questionnaires for people who were using the St Anne's unit and the Harrow Arts Centre unit, and people with disabilities were saying they liked to be able to go and have supervised testing, and because they felt that they were doing it right. It was more accessible. It was more difficult for them to do at home, or more difficult for them to access home test kits. We'd also look at pregnant women and new mums, so that we're protecting babies from getting COVID, and homeless families, because there tend to be issues there with overcrowding, and obviously much more deprivation in those families. So alongside the mobile pop-ups, of course, there's the community outreach and how we actually get people aware of the testing offer. We look at making sure that our staff and other staff know, and we work on making every contact count. So we talk a lot about that through health and social care, trying to make sure that when we do contact somebody, that we actually do make sure that we talk to them about testing, and we talk to them about symptoms, and make sure they're aware of what's available, and potentially distribute test kits as well if that's thought to be a suitable model. So quick words on vaccination. It's nearly 150,000 people in Harrow have had one dose of the vaccine, and the vast majority of them have also had their second dose. But we do have some significant differences, and the differences in testing and the differences in positivity rates and vaccination all sort of focus on particular areas. So much more common in deprivation, areas of deprivation, to get COVID it's also less likely to get tested and less likely to get vaccinated. So we do need to focus on those areas of deprivation. We also need to focus on some of the communities. So you can see here the uptake by different ethnic groups. And if you look at the white British, the Asian Indian, Black, any other Asian, and the white Irish groups, they're all quite high and quite similar. But if you look at the Black African, any other Black group, Black Caribbean, mixed white and Black, and some of the other smaller groups, the rates are very, very different, and we need to get those rates up. So we're doing a lot of work with our on our COVID awareness fund with the community champions to make sure that they're getting those messages out. We use those consistently when we've got pop-up clinics, so they're aware, and it's been quite useful having them to make sure that people who are not registered with GPs, for example, or who are undocumented, still get vaccinated. That was very, very successful in the Roxbourne pop-up clinic that we did a few weeks ago. And that's just a graphic to show you the dark blue is people who've had 1 dose, the pale blue is people who've had 2 doses. And you can see that in the majority of the vaccine cohort, most people have had 2 doses who've been vaccinated, but there is this grey group here that we still need to vaccinate. And obviously the younger cohorts down here who haven't had as much access to vaccination and haven't been eligible for it for very long have got lower rates, but that's coming up all the time. So I'm going to stop talking about vaccination and I'm going to let Lisa take over and tell you about what's going on.
Thank you, Carol.
Thank you.
I just thought it would be useful to supplement Carol's presentation on testing and sort of what we're seeing in terms of population uptake on vaccine, just to highlight some changes in the way that vaccination is being delivered currently in Harrow, present our latest position in terms of vaccination uptake and performance, and some of the focus areas over the coming weeks. So probably since I last presented to you, I think with this approval was imminent at that time, and now it's firmly in place that the mass vaccination centre that's based in Byron Hall in Harrow is now delivering both types of vaccine, both Pfizer and AstraZeneca. It started operations on the 8th of June in this fashion, and patients are able to book into the mass vaccination site through the national booking system, which is available through the nhs.uk website. Our primary care-led operation that was running from Byron is now closed. Our GPs, as we will come on to later in the agenda, are seeing particularly increased demand for general practice services. So it's allowed many of those practice teams to get back to their practices and on with what we call their business as usual. They completed most of the second doses for cohorts 1 to 9 and those first doses, so that's our over 50s. And the second doses that remain for those cohorts, as well as the first and second doses for our population under 50 years old, are being transferred to be delivered under the mass vaccination centre at Byron. We are complementing the mass vaccination centre activities with pop-up sites. Carol mentioned 2 that we ran a fortnight or so ago that were really successful. I'm sure some people may have seen some of the media coverage around that and the flocks of people that came to get vaccinated, which was so fantastic to see. We vaccinated on the Saturday at our Roxbourne Medical Centre, and 500 people accessed vaccination there. And we operated on the Saturday and the Sunday at our Belmont Health Centre and did just short of 2,000 people over that weekend. And I think that what was really nice to see about those vaccination activities it wasn't just young people coming through, it was a multi-generational activity, and many younger people were bringing parents or grandparents with them for vaccination and encouraging them to access in that way. So that's definitely something we want to build on, and we're looking at how we continue to run those pop-up arrangements in Harrow. In addition, we continue to try to secure additional pharmacy provision, particularly in West Harrow. East Harrow we were looking at, but actually there are some pharmacies that are just over the border in Barnet that are providing vaccination. So we're concentrating on West Harrow as well as our central areas to support access to vaccinations. Alongside that, so that I didn't put on the slide, there do remain some patients who've become housebound or who were housebound but maybe not well enough to have the vaccine when we first offered it through our housebound programme. So we continue to vaccinate those patients who need us to go to their homes to do that. This is a slightly different view to Carol's presentation on the vaccination uptake, but this is our current rates around first doses. We obviously have been really focusing since December on our over 50-year-olds, and now we are open to everyone over 18 years old. So that's why that percentage is lower. I think it is interesting that we still have some way to go with our 40 to 50-year-old population who have now been offered, but are definitely going to need some follow-up to move that coverage up. And of course, this is an evergreen offer for our older population as well. So even whilst our percentages are very high, we continue to encourage people to come forward so we can aim to vaccinate as much of our vulnerable population as possible. And then the next slide shows where we are in terms of the percentage of the second doses as a percentage of the first doses that we have given. So Harrow is doing really well on this front as well in terms of bringing those patients back for the second vaccination. We contact people via text message for booking. Many of these were booked in on leaving for their first vaccination, but for those who haven't come, we chase by text message, and when our PCNs were operating, they were doing numerous phone calls to these patients as well to follow up. So considerable efforts are being made, and we're also trying to offer a more flexible model for people to come forward for their second vaccination. So a combination of booking people in, but we've also been offering walk-in services at Byron Hall in the afternoons to encourage people to come forward and take up that second vaccination there as well. Just in terms of where Harrow compares to national London and Northwest London averages, this week some data was published on the BBC website. So this is very much in the public domain around population uptake rates. London as a whole is not performing as well as the England average, and I think that we could probably have a long discussion on the factors that are influencing that. But Harrow is doing very well compared to the rest of London, and has in the Northwest London cluster has the highest overall population rates who are vaccinated, both for the first dose and the percentage of our population that has now received that second dose. So that is good news for Harrow, but we will not rest on our laurels and continue working through this programme. I think I may have couple more slides. So as everyone will be aware, the period of restrictions has continued for another month, and really this month is about continuing our pace around vaccination and working to vaccinate first doses, as many of our 18-year-olds and over as we can, as well as delivering our second doses. So we are being flexible in when people can come forward to access those second doses, and we're moving it so people can have that between the 4 and 8 week period where that's appropriate. We continue to maximise the uptake of the first dose in our younger populations, and we are focusing our lower uptake on our activity in areas where our vaccination rates are lowest, and the example of that being our activity in Roxbourne and Belmont. So to conclude and just to summarise, just highlighting those changes in the delivery models and how we are communicating those through to people around how they can access vaccinations. A key message that our vaccination uptake rates remain strong in Harrow, but we continue to focus our efforts to make sure we can get maximum coverage for our population. And something that we are very focused on as a local Harrow team across the NHS and local authority is that whilst we are chasing numbers and we are trying to get maximum uptake, we cannot forget within doing that those sections of our community who are more hesitant to come forward. So we continue our focus for coverage for all of our population.
There he is.
Okay, thank you. Are there any questions and comments on the presentation? Councillor Michael Borio.
Thank you, Chair, and also thank you, Carol and Lisa, for the update and presentation. Firstly, I just wanted to give a non-pecuniary declaration of interest in that around the discussion about testing in schools. I work for the Department for Education. Sorry, I should have probably brought that in earlier in the beginning of the meeting. The actual question I had, though, was around, obviously it's very encouraging, vaccination programmes, stats overall, but particularly in Harrow, but more work to do. Looking ahead to the autumn, though, obviously there's a lot of speculation, hasn't been confirmed yet, that there may be some sort of booster programme that will need to be rolled out. And I just wondered what sort of contingency planning we've done in terms of preparation for that. Obviously, with the vaccination programme, we've had a much longer time to roll it out from, the beginning in December right through to this summer, whilst this autumn we'll have a much narrower window, particularly with COVID rates likely to rise at the end of the year as temperatures drop. And so I wondered what sort of contingency planning we've been doing for that, but also as well, would we consider, in addition to having the vaccination centre in Harrow, could we also consider maybe going back to the earlier model where we had other centres as well localised, like for instance in my own ward in Queensbury. I was quite pleased to see that we had the hive as initially, and I thought that obviously, it's dependent on vaccine supply as well. That'll be a major factor. But if we do have the vaccine supply, it would be good to have localised, mass vaccination centres as well as the one central one as well. That's my question. Thank you.
Yeah, can I kick off? I think as far as the vaccination boosters go, I think the most likely scenario is that it will be for people who are in the 1 to 4 cohorts rather than for everybody, because the majority of people will still be protected by their 2 doses. But the people who are in the vaccine cohorts 1 to 4 will have been vaccinated first, so that any waning of immunity is likely to happen in them more than the rest of the community. With regard to planning for that, I don't know whether Genevieve's got her hand up. I don't know whether she was going to say something about that.
Thanks, Carol. So hello everybody. I'm Genevieve Small.
Hi.
I think I'm clinical director for North West London CCG. No, I'm not. I'm the clinical borough lead. Hi. There's a lot of research going on at the moment about what will be the approach. They are doing a number of different trials, basically looking at what would be the right vaccine to give as a booster, who should receive it, so picking up on Carol's point, and then thirdly, what happens with the fact that also in the autumn we do our flu vaccination programme. So that will be very important this year, because we recognise that we were very fortunate last year that we had good uptake from the flu vaccination programme and we didn't see flu in the country really. But we don't know what the situation will be for this autumn coming. And so it will be important that people who are vulnerable to flu who are also the people who are vulnerable to COVID, we managed to manage that. So we have not received the details as yet. We do expect them in the next few weeks, because that's important, because we will need to plan it. But there's a number of different options of how that will be administered. I'm sure that we will work collectively together to do that. Obviously, Carol will have her public health need to deliver both types of vaccine. But we do know, and this is probably just something that's worth adding, is we know our pharmacists have been really good as well, delivering the COVID vaccine as well as delivering the flu vaccine in the past. And so I'm sure that whatever system works for the requirements that they advise us to deliver, we will be looking for a combination approach of the large delivery and the smaller bespoke delivery.
Thank you.
Thank you.
Councillor Veena Mithani.
Thank you, Chair. Thank you for a lovely informative presentation, both of you. Carol, I just wanted to know how many sort of cases of Delta variant do we have in Harrow, or are these all positives, which are positives are Delta variant? And you said the case numbers were rising, but not like in same boroughs, but they are varying. Are this family sort of like outbreak, and have you traced where they've picked up the virus from?
So I can tell you, I'm frantically trying to open the right document so that I can give you the accurate information. So at the moment, it looks very much like around about 98% of the variants of the COVID cases in Harrow are due to the Delta variant, and only 2% of the cases are due to the Alpha variant. And that is pretty similar to the rest of London. And so, you know, it's not a surprise. It seems to be what's happening through most of the rest of the country at varying rates, replacing one variant with the more dominant variant. Yeah, we are seeing family clusters. What we're not seeing is we have seen some outbreaks based in schools, or we saw a stage school that had also got an outbreak. So we've had you know, a number of these across North West London. But the vast majority of cases are happening when one person gets it, then they spread it into the other people in their household. So we do get those jumps if you've got a large household with, you know, 3 or 4 kids, and perhaps grandma lives with them as well. You know, they might all get it, but hopefully grandma doesn't get it because she's been vaccinated. So you know, but it is really very variable about where people get it. Everybody is asked when they're contacted by Test and Trace, or whether it's our team or the national team, they're asked about where they've been in the days before they became ill, so that we can test people when they potentially were able to transmit but were asymptomatic. But they're also asked about where you were in the last week, so that we can try and trace that. What we're not seeing is any consistency in patterns. People are not saying I was in a particular venue. I was, you know, so we're not seeing it associated with anything. What I suspect is that, you know, given the age group, it's the 17 to 24-year-olds. A lot of that transmission is probably happening in the pub, Although that's not sort of coming up as something that they mention, but I suspect that there is quite a lot of that, and quite a lot of social mixing with young people. It's what young people do. They've been locked down for a long time. You can't blame them.
True. Yeah. Can I just ask one more question, Chair?
Okay.
Carol, how are you reaching those groups? I know we had talked about ethnic minority and like Romanian groups and Somali groups. Have you had any sort of like luck approaching different communities? And how are we approaching various communities so they can increase their uptake of vaccine in Harrow, especially the groups you mentioned?
Yeah, we have a very, very good set of community champions, COVID champions, who we meet with on a regular basis every week or two, and we talk to them about the current situation. They bring to us the community intelligence. So they tell us what people are telling them. So we find out about the myths and the rumours that are going around. We find out, what people's fears are about the vaccine, and then we help them to phrase the answers to them in a way that they can actually pass on in their communities. So, they talked about fertility and being afraid of AstraZeneca vaccine and what about side effects of vaccines. There's fears about all sorts of things, and things that you wouldn't even think about, but I think what's been good about those groups is that they are really embedded in their communities. And one of the things that I mentioned before about the Roxbourne pop-up clinic is quite a number of people that turned up to the Roxbourne clinic weren't actually registered with GPs, and we saw that particularly from a Ghanaian community, and that was purely and simply because we've been able to reach out to that community group through somebody that they trusted, and they were able to pass that message on. So they came to the centre. So I think that the model is working. It's not to say that it couldn't be better, and we could do more work. But I think we are getting those messages out. We're also talking about doing videos with different communities so that they can spread the message through a video in their own language. We're doing radio adverts. So we use the people who do the digital radio advertising. I didn't know this before we were doing this. So if you listen on to one of the national radio stations or one of the London radio stations on your digital machine, the ads are tailored to you, and which I shouldn't be surprised at it. I mean, they do it on Facebook and on YouTube and everything like that as well, don't they? But so you can, they'll tailor it to our communities, and they'll tell them about getting vaccinated in Harrow, and it's actually got a huge amount of reach. And is not particularly expensive for the reach that we're getting for that. So we are trying to use lots of different and innovative ways of getting out to the communities. And we're always happy if people have got other ideas about how we can do that, what might work. We'll try anything to try and get people vaccinated.
Lovely. Thank you very much, Carol.
Thank you. Councillor Karima Marikar.
Thank you, Chair. Thank you, Carol and Lisa. Well done. Good presentation. and I'm very impressed. And I, as you know, Carol, I did voluntary work in doing the PCR test in Harrow Council. It was very well organized. 100 marks for that, Chair. In my point is, there's only a simple question. I saw the priority coherent for Harrow, the BAME community. You all have categorized and saying Tamil, Somali, Romanians. But Tamil is a language. You must understand Tamil is a language. Tamil. So if you put Tamil community, it falls under the category as Hindu community. Do you know that? Tamil, because that has happened even in the CAB, in the Citizen Advice Bureau, and I was explaining, because originally I'm a Sri Lankan, but I speak Tamil and Sinhalese. So there are Sri Lankans who comes here, right? Yeah. And they are categorized as Sri Lankans. Do you understand what I mean? Yeah. So like this, if it is Tamil, where do I fall as the Muslim community? Do you understand what I mean? Yeah. So if you categorize as Tamil, I don't think in a wider majority community-wise, because I think every community has to be targeted. Every community, there is people who are doesn't understand the reality of getting a vaccine, getting this done. Because we work, I work, and you all work for the trust, and you all know exactly this has to be done. So I think the wording of Tamil community language, putting leaflets, yes, fantastic. But if you categorize as Tamil community, where are the other communities going to go? I'm not an Arab, I'm a Muslim, but I'm Sinhalese speaking and Tamil speaking. So where am I? I'm saying just example. Yes, so no. That wording has to change in holistically, and I think it has to be debated that whether to change or not. I thought I'll just try to put it in. Other than that, I'm sorry, Chair, I have to go for another meeting, which you know, Chair, and as I told 7:30, I will have to leave, but I will be in the meeting. But if there's a questions, I'll come up. Yeah, is it okay, Chair?
Yeah, that's fine. You can send us in writing as well if you can't make it today for questions.
Yeah, but I will be listening because I have to go into the other meeting. Thank you so much, Carol. Thank you so much for everybody. Thanks.
Thank you. Okay, Councillor Leslie Lewinson. Leslie, would you like to ask your question?
To Carol and also to Lisa. I don't think any of us will forget the horrendous situation that happened with the COVID cases in care homes at the beginning of the pandemic. And I was just wondering, what is the latest position on vaccinating care home staff?
A lot of the care home staff have been vaccinated, and it does vary from care home to care home. So we do have some care homes where it's 100% vaccination rate, and we've not had any problems. And we do have some care homes where it could be better, and some care homes where it could be a lot better. And at the moment, we're working with them to try and encourage people to get vaccinated. As you know, there's been a discussion about making it mandatory for people to be vaccinated. And so we're working with the care homes to actually identify how that will happen and what impact that might have on their businesses. Because if people are adamant that they don't want to get vaccinated, they may not be able to work in care homes in future. So that is a concern, that we get that message across, and so that we can still maintain that workforce. I know Angela's on, and I don't know whether she wants to say something about that.
Yes, Chair, if that's okay. Do you want me to expand?
Yeah, that's fine. That's fine.
Yes, so you may have seen the headlines in the news recently about the wish for government to ensure the mandatory vaccinations for care homes for staff and for people visiting the care home as part of their work. So hairdressers, beauticians, social workers, etc. So it's going before Parliament, and if it's to be passed, it would be implemented in October, and there'd be a 16-week grace period to allow the people to have vaccinations before that. So obviously you can imagine it's quite controversial in some areas, for and against. And we're, as Carol says, we're working very closely with the care homes to support them and constantly reinforce the benefits of the vaccination. And so that's across the council, CCG, our community providers. There's a really strong response to support care homes.
Thank you.
Okay. Can I actually ask a question, please? Oh, sorry. Lisa, do you want to come back to this question for this question?
It was only a minor comment. So we have been asked now to be looking at this very regularly around the uptake of both care home residents and workers in each of our care homes, and we are now required to be reporting to NHS England weekly on our uptake rates. I think huge efforts have gone into this so far. I know through the local authority teams and our GPs have run a number of sessions with care home workers to try and support people in any queries that they have. That offer is very much still open if people would like conversations on a one-to-one basis or as a group. So we continue to work with our care homes on that. Okay,
thank you, Lisa. Okay, what is the latest position of vaccinating children in high schools from autumn term?
At the moment, the UK hasn't approved the vaccine for use in children. It's been approved by the European Medical Agency, but it hasn't been approved by the MHRA. I suspect it will be at some point. Thinking globally about the use of vaccines, I would question whether it's more important to vaccinate younger children who are not suffering from COVID very severely and are not being hospitalised with COVID, compared to countries that haven't got access to vaccination and where people are dying in their thousands or hundreds of thousands. And so from a global perspective, you have to think, we're not all safe until we're all safe. And I would be advocating for those vaccines to be used in other countries rather than to be used in Britain for vaccinating children. I think it's a difficult area, and I think that there are people who are going to be very pro-vaccination, who are very keen to get their children vaccinated to protect them. There will also be people who are very anti getting their children vaccinated. So I think it's going to be a balancing act, but at the moment, I don't know when or if it will get approval through MHRA. But that's my personal opinion is that I think the vaccine would be better used in other countries where vaccination rates are lower.
Okay, thank you, Carol. Has planning started on the autumn-winter vaccination program?
It started on the flu vaccination program, but at the moment we're still waiting for the announcement about what the autumn-winter COVID booster will look like. We're expecting that in the next couple of weeks, so that we can do all the planning for that. We're waiting with bated breath.
Okay.
I'm hoping that we get a gap in between finishing this one and starting the next one.
Sure. Thanks. Okay, just last question. I might be able to send you a question because I want to finish this by 7:30. This is about long-term financial impact of COVID-19 on health and social care providers.
Yeah, I don't know whether Angela or Paul want to comment on that.
Yes, no, I'd be happy. Was there anything in particular? Was it in regarding to the care home providers or?
Yeah.
So as we do get weekly figures from all our care home providers. They fill it in a form, what we call capacity tracker, and part of that is looking at the financial impact. So there are a number of voids across the country in care homes, and we're watching very carefully and working with our providers to see how we can use those voids in different ways. But there are parts of the country, not in Harrow, who unfortunately the providers have had to close down as a result of a number of voids, but not in Harrow. We haven't had any service failures in Harrow. But it is a concern as we go. Some providers are evolving and doing different things. And of course, we are finding that the need of our citizens in Harrow has increased, and we are in fact placing more people now in residential than we were before. But we're very conscious of the effect that COVID has had, devastating effect it's had in the care homes, but also the impact it has for the businesses of running care homes. So I see Lisa's got a hand up. She might want to add to that.
Hi, Lisa. Thanks.
So just responding from a health perspective, over the last financial year of COVID, in many ways, the contractual arrangements we have in the NHS changed to protect providers of service from income loss over COVID. So a lot of we moved on to what we call block contracts rather than item of service contracts, because essentially the pattern of the way people accessed healthcare changed very significantly. So essentially guaranteed an income at the same level of the previous financial year. So in many ways that was to support providers. The healthcare system as a whole, I think we are yet to see what the longer term financial impacts of this will be. We are seeing, and we will come on to it, I'm sure, in the Health Watch report, where a lot of activity for urgent care reduced dramatically. It's absolutely picking up again, and that's often what's driving financial pressures on the healthcare system. And we're also managing a whole set of new conditions, like post-COVID conditions, as well as some very complex mental health needs of people as a result of the pandemic. So I think all of those implications are yet to emerge for us.
Thank you very much. We can move on to next item. Thank you to everyone. Progress on the integrated care partnership in Harrow. So please may the report be presented in brief.
Thank you. Sorry.
Okay, so you will remember at the previous scrutiny we had a position statement on the health and care partnership as it was proposed and planned in Harrow. Tonight we have a progress update, and we have partners on the call who are very much integral to the work. So I'm hoping that you'll find the presentation very informative. Lisa, I think you're going to start and then others will contribute.
Thank you.
Thank you.
Share the slides, Lisa.
Thanks so much, I hear the request for a brief presentation, Chair. What I might do is just talk us through the slides, and then yeah, it's wonderful to have so many partners from across the Harrow Health and Care community on the call, and so I think a discussion on all of these aspects of care that we're covering will be really useful. So as Paul has said, you have received sort of an update statement before, but really just wanted to provide a bit of the overview and go back to where this concept of an ICP has emerged, how we've built it in Harrow, and what our priorities and work programme is at the moment, taking that forward. The Integrated Care Partnership, and what we call in Harrow our Harrow Health and Care Partnership, that is our local integrated care partnership. It's really at the heart of a lot of the system change that we're seeing in health and care services at the moment. but in many ways probably the least defined that people will have seen in policy or legislation. There's been a lot written about the integrated care system that we will have at North West London level, and that will be set up as a statutory body from April if the legislation moves through as expected. And that's essentially the system level of the integration. And then at a real neighbourhood and real local level, we have our primary care networks. And again, there's been a lot that has been written and understood about the role and function of primary care networks. The integrated care partnership sits at that place level or the borough level, and is extremely important for serving the population within that defined area. In many ways, there hasn't been so much written on what their exact responsibilities will be and what their form will be. And so these are very much evolving across the country at the moment. But what we are seeing is an increased focus through government departments on sort of the primacy of that place and the importance that these local integrated care partnerships can bring in terms of serving the population and bringing those local partnerships together to meet population health needs. In Harrow, we've been working to develop a highly functioning integrated care partnership for some time. In the past, this has been very much driven through our whole systems integrated care model and how we are integrating and bringing alliances of people together to improve health and care outcomes. We got the first formation of a team to support that work back in August 2017. And then we moved from sort of piloting and prototyping ways of working together to actually scale this up and really accelerate the change in the form of our partnership across the system. And so that really sort of came together in 2020, where a Harrow Joint Management Board reaffirmed the vision and objectives of an integrated care partnership in Harrow and set out a clear roadmap for how it would deliver improvements at scale and build on the future health and wellbeing for the people of Harrow. The Harrow Health and Care Executive was formed in February, and it brings together system leaders from across the local authority, including public health and social care within the local authority, the borough team of the North West London CCG. All of the clinical directors of our primary care networks are part of this executive, as well as our community and mental health providers, our acute services, the London North West, voluntary and community sector partners. Originally, this group was brought together to oversee a 100-day programme of joint work across Harrow based on that roadmap and remained a focus, but then COVID came in and actually became a really key focus of this partnership, and the partnership itself became just the central vehicle for coordinating Harrow's pandemic response and was then designated as the Silver Borough Command for the pandemic as well, in terms of responding to our urgent situations. As we exited the first wave and just before the second wave, we published as a partnership our out of hospital recovery plan, and that was a plan that was developed jointly across all partners and was recognised at a national level and became a model across London for how partnerships could come together for recovering from COVID. We looked at our commitments that we had as a partnership, what we'd learned through COVID, what had really been fundamental in bringing those partnerships together, and thought about how we could use that to both recover from COVID, but also redouble our efforts in terms of addressing health inequalities in the borough. We continue to build on that out of hospital recovery programme, but we are using now, as we are exiting the second wave and moving into our second stage of recovery, actually how we can continue to develop, but also how we really place patients, citizens and communities at the heart of everything that we do. We are reviewing what the partnership has achieved in its first year of being established, but how we maintain these key principles of being accountable to local people as we move forward to develop our integrated care offer in Harrow. So what is an integrated care partnership? I think I've probably talked through some of that, but it can really be defined by these four key areas that are outlined on this slide. So it's about integrated design, planning and delivery of services. It's about all areas of the health and care system coming together to deliver real change from both how we jointly design services, how we deliver them and how we hold each other as a partnership accountable alongside local people for how they're delivered. It's about having a shared leadership, finance and governance structure So we all within this partnership well understand our roles and responsibilities for delivering them. It's moving us towards a shared financial understanding across the system and looking at opportunities to increasingly pool our resources. So our efforts become much more about what our population need in terms of the services we provide, rather than historical contracting arrangements we have in place. And that we've got really robust governance in place across our partnership so that our decision making can be transparent and, again, in the interests of the Harrow population. A lot of the work we're doing at the moment is really defining how we want our cultures and how we want to behave as an ICP, and as we move forward into the new system arrangements. Having shared visions and values from that, sharing the outcomes that we want to deliver, being really clear about what good looks like for our population, and holding each other to account to deliver that. And finally, around our organisational structures, this is a little nebulous at the moment, but what we're taking is a pragmatic organisational structure to operate effectively and enable collaboration. So the ICP at the moment is not an organisation in its own right. It's a collection of organisations coming together with a common purpose and these shared performance metrics to deliver. So the plans have been significantly impacted by the pandemic, and it's been a key focus of the partnership, but we have continued our work around a number of joint priority areas, and these are listed here. I'll go into a little more detail around each of these work streams in a moment, and partners leading these work streams are on the call. But just to briefly run you through, I'll come to the work streams then when we go. So in addition to running those work streams, we've also taken the opportunity now to reflect and refresh 1 year on within this partnership. We've been looking at these 5 different areas. First of all, our overall lessons learnt, what we've done well, what we would like to do differently, and how much it feels like we're operating as a system, and making sure that's really embedded. It's not just about a group of individuals with goodwill and good relationships between them, but that actually this is becoming the blueprint for collaboration across all of our areas. We're looking at how we're enhancing our support to primary care, and within that the critical role our primary care networks will play in actually making this integration happen for local people. So seeing how we can best support that. We're responding to the Health and Social Care white paper and what it's saying about ICS is forming, and what we think that means for an ICP in Harrow locally, and the importance of that place-based working within the integrated care systems. One of the challenges for our partnership will be addressing our resource challenges, looking at really how the partnership activity can really support some of the financial position across the organisations, and how we jointly manage any financial challenges going ahead. And that we really focus on addressing our future priorities, health inequalities, making sure our system flow is right, and that we are maintaining our progress around discharging patients, addressing long and post-COVID symptoms, supporting mental health, growing our critical care capacity and diagnostic capacity, and understanding sort of with that existing set of work streams that we have in place, how we take those forward and continue to build on them in the future. This slide contains some of the comments from the review that we did around the first year of the Integrated Care Partnership in Harrow. I won't read through of these, but I think the key message here is that there is a strong agreement across the partnership that the Health and Care Executive has been central in improving joint working across organisations in the last 12 months. And I just read the highlighted comment here and leave you to read the rest at your leisure. But I think this really captures the aspirations of all partners who are around this table every Friday morning, that I want the Health and Care Executive to be the voice of the Harrow population within the integrated care system, and to give Harrow citizens the best caring services they deserve by bringing in the resources to address inequality and comorbidities. I think the aspirations everyone in this partnership has for the population are very strong and provide us with a good foundation to move forward. So after reviewing the first year, we're now taking forward a series of conversations through June and July to build our ICP to get it set up really strongly for the future. We're covering 4 areas. The first two we have held already, how we put patients and citizens at the heart of the ICP and how we hold ourselves to account to each other and to our citizens in doing that. This coming Friday, we will be reaffirming our shared delivery commitments, and then finally looking to develop our shared culture. Just to highlight some of the work we did around putting patients and citizens at the heart of our ICP, we sent invitations to a range of community groups, many of which we've developed strong relationships through the COVID awareness funding. And we had some really excellent conversations with those groups on Friday of last week, where the health system leaders, so members of the Health and Care Executive and the Joint Management Board, facilitated very small group discussions for the first hour of our Friday meeting on very open topic of really hearing how people are experiencing services, both that are treating people when they need care, but also services that support people to stay healthy, what people value about them, what's working for them, but also where we need to see improvement. We have a real focus in these conversations that we weren't just going out and asking people to repeat their priorities and failing to deliver on what we're told, that these sessions have been about us really helping to find the what that people need to see delivered in terms of health and care in Harrow, and that as a system leaders, we commit to the how we are going to take those forward. This is a lot of detail. I won't go through them. I said I think this there's lots of people on this call who'll be able to answer specific queries about the work streams that we have in place. But just sort of broadly giving an overview of where our focus is: frailty and care settings. So that's care for our frail population who are both in care homes but are also being cared for in their home settings. Mental health and well-being, learning disability and autism. Key area around prevention, self-care and social prescribing. We have group on long-term conditions, one on children and young people. And then just going to the next slide, IO, tackling inequalities. We have a carers subgroup, and then we have essentially what are our enabling work streams. So looking at how we're integrating training and education, our digital transformation programme and communication and engagement. So in terms of presenting this today, the ask to the group is to note the update on the developments of the integrated care partnership in Harrow, and I hope that has been a useful overview of where the partnership is in its development. We very much welcome comments or questions about any aspects of that development or how we can continue to strengthen the relationship between this subcommittee and the work of the ICP. Thank you.
Thank you, Lisa. Okay. Are there any questions and comments on the presentation? Oh, Councillor Veena Mithani.
Thank you, Chair. A really comprehensive work stream and work plan, so thank you for that, Lisa. My question is, does the CCG come under you, or the CCG will be a totally different sort of stream, and would you be working closely with CCG because we've got a single CCG in Northwest London?
It's a confusing picture at the moment, isn't it? So yes, we are now a single Northwest London CCG. My role is that I am the Borough Director for the Harrow team. So essentially the Harrow part of the CCG comes under me, and the CCG is very much part of this health and care partnership. But of course the CCG will be dissolved as a statutory body from March, at which point we become a combination of the wider integrated care system, but also very much as a borough team still part of our integrated care partnership.
Can I just have a supplementary? So how will the budget work for like Harrow? Will it be portioned, or how will the whole budgeting, and how will the GPs sort of get their funding, and will it be by number of patients?
So the GPs work on a national contract, which is set at a price per patient. So in many ways that isn't changing. There are other aspects to the way that GPs get paid, as well as some other local services. So at the moment we have certain budgets that are delegated to us as a borough team, and primary care is one of them. So the way the GPs get paid through their national contracts, as well as some supplementary or additional services that we arrange through general practice to meet the needs of our local population. The budgets for medicines management are part of our local team, as well as the pooled funding that we have within the Better Care Fund, as well as some joint commissioning arrangements. Many of the budgets that have moved to a North West London level are some of the larger contracts that we have with, say, hospitals, where the hospitals are serving more than one borough, and actually it makes sense to hold them at a North West London level.
Thank you.
Can I invite Maury Pat?
Good evening, thank you. Sorry, I'm the operations manager for Healthwatch Harrow. It was really an observation rather than a question, because I think there's some excellent work going on, and we've seen the evidence of how well the Harrow Health and Care Executive are working. It was just really from a Healthwatch perspective, the concern that we still have, and I think this is partly because everything is still evolving, but it's how we make sure that the patient voice of Harrow, when I say patient, I mean resident, because it's both health and social care, is heard at that North West London level. I say I don't expect an answer here because I think it's something we're all still evolving with, but it's my key role is to make sure that that voice is heard, and that's the bit I look forward to seeing how it all moves forward. Thank you.
Thank you. Councillor Marikar, are you there? Hi, do you want to ask a question? Can't hear you.
I have to go. Lisa, fantastic presentation, because you have really done the right job. I think that's the good way to go forward in the health and social care. I really can't understand whether you're going to take the new service care providers to join the CCG for policy making and so forth going forward. I don't know.
So. Sorry, I think you've just gone back on mute, Councillor.
Sorry. Are you okay?
I may have lost it. I think it's a really interesting question around how providers, sort of the role of commissioner and providers, which really is a distinction that's changing within these new integrated care system arrangements. So it's much less about a commissioner having the money and contracting with a provider for a set of services, and it's much more about the organisations and people serving a healthcare system coming together and looking at the resources they have to meet the needs of that population. So less about this transactional relationship and much more about the collaboration that we have in place. I can see Genevieve has her hand up and wonders if she.
Yeah, I'm going to bring her in
as well.
Right, thank you, Genevieve. Would you please come in?
Yes, thank you, Councillor Shah. So I think that it's interesting that people have struggled to know over the years what has the CCG been doing, to be honest with you. So I think that it is with a slightly wry smile that I now see people worry about what happens when the CCG is kind of like not going to be there anymore, because I don't think people really kind of like we ever articulated terribly well what we did do, but I think that Lisa's absolutely right. These are emerging structures, these are emerging partnerships that are coming together, and I think we actually I have great confidence that as we move into the future beyond April 22, when we have a different statutory authority in the integrated care system for North West London, Harrow will have a very strong voice in that partnership, and the foundations that we're setting now in the health and care partnership will actually serve us incredibly well, because we are demonstrating by working together constantly how actually provision of health and care should work for the Harrow resident. And the stronger we are coming together, the more actually we're able to demonstrate to the rest of North West London that Harrow understands its needs of its population and actually listens to its residents. And I think that Marie is absolutely right, that the voice of the patient is crucial, or the voice of the resident, as I should say in this setting, is crucial to the way that we plan our services and deliver our services going forward. We won't get everything right. There will be things that we need to tweak along the way, but actually the CCG currently in its North West London form and in the future as an ICS at North West London, they need to just have that confidence to know that Harrow is getting its act together to deliver together, and that's what we're doing. So I'm full of confidence for the future.
Very pleased to hear that. Veena, do you have a question? Your hand is up.
I don't know if it is the right forum to ask, but because Lisa, you mentioned about the patients and the GPs contracts. At the moment, we are receiving quite a few complaints from the residents that this has been ongoing about, telephones not been answered. So that's nothing new. But the new thing is that when they want to have a face-to-face consultation, they are not getting. It's video consultation or telephone consultation. A majority of people have been vaccinated now. So the question from the residents is, why are we not seeing our GPs in person? And why such a delay? So I don't know if this is the right forum to ask the question, then please do give me an answer so I can go back to the residents.
I'm happy to answer that if you're happy to take the question.
Yeah, that's fine.
So I'm really hearing this, and Genevieve and I met last week with all the chairs of the patient groups in Harrow, and we've seen reports come through from Health Watch, and we're absolutely understanding that people really are missing seeing their GPs face to face, and are struggling to get those face to face appointments with them where they need them. So I think general practice has continued to offer face-to-face appointments through the pandemic, but it's been through a triage model. So someone's been spoken to on the phone or through an online consultation or a video consultation, and the GP has ascertained if a face-to-face appointment is needed. And in many ways that still continues. I appreciate the view that people have been vaccinated, but general practice is still having to work under operating procedures around infection prevention and control to protect their workforce and patients that are coming in. So there still does have to be some limitations on the number of patients who are physically coming into the practice. So this process of speaking to someone in the first instance and offering a face-to-face is needed is currently still in place. What we are really hearing, though, is that actually some of the online consultations are really challenging for some parts of our population. And I think what we're seeing is patients where that's not working, that actually people are going elsewhere in the system to seek a face-to-face appointment. And I can see Simon from London North West on the call, and he will absolutely be experiencing this through the urgent treatment centres and A&E, where people are voting with their feet and going in that direction for face-to-face appointments. So Genevieve and I had this meeting last week. It's absolutely something we are taking seriously. We will meet tomorrow. We have over 100 GPs in Harrow join our call, which is fortnightly on a Wednesday, and the majority of the agenda tomorrow will be feedback from the meeting we had with patient groups, reflecting the comments that people are having, the challenge that people are having, and actually trying to work together as a Harrow primary care community to think about how GPs are are dealing with this, the need for urgent care and face-to-face appointments, but there is a huge backlog that general practice is trying to manage as well, where a lot of the long-term condition care was, where it was safety, it was put on hold to allow the GPs to focus on the vaccination programme. We're trying to come back and deal with that, but the demands on general practice are like never before. So it's trying to get that balance right of responding to what we are hearing people say they need, but also trying to work out how general practice can navigate through this exceptionally busy period. So I'm afraid I don't have a clear answer to your question, but we're absolutely hearing it. If patients really feel they need a face-to-face appointment, then that should be part of the conversation they have over the telephone or on an online consultation, and asking for that face-to-face appointment. And we'll continue conversations with our GPs on how we can secure that.
Thank you. Good evening, Simon. Would you like to come back? Simon Crawford, say something.
I'm happy to say something about. I won't comment particularly on what Lisa said around the GPs per se. What I can say is that we, over the last six to 8 weeks, we have seen increasing numbers, both through our A&E and certainly through the urgent treatment centre. And the urgent treatment centre has been overwhelmed, I think, over the last 3 weeks in terms of the volume of patients attending, and it is resulting in patients queuing outside the door, and that does represent a safety risk, really, where the volumes are that high, because when they're queuing outside the door, they're not getting an immediate assessment in terms of the degree and presentation. So the risk is those people who are not as acutely unwell are detracting from the ability from those who are acutely unwell to be assessed quickly and channeled through the right routes, both through the urgent treatment centre and potentially through A&E. So it is a real challenge and an issue. We have had discussions with the urgent treatment centre around what they can do to help themselves, and certainly, because we don't actually provide the urgent treatment centre ourselves, but we are supporting them. We have put additional staff from A&E to support them at the peak times, but we've had several meetings with them now in terms of escalating what they need to do to try and manage that. But equally, there have been further conversations around what else we can do around referrals, because it's not just the GPs, it's the 111 service also directing into the UTC as well. So we are having system conversations around that as well. But we're not alone at Northwick Park. Similar challenges have been being expressed at Hillingdon, and certainly we're seeing it to a degree at Ealing as well. But it is a real issue.
Thank you. Julian, would you like to come in?
Thank you. I just wanted to say that we have noticed that there is confusion with patients in the case that returning to normal, which is the phrase of coming out of COVID, think we're going back to a GP, getting appointments with GPs the way it used to be. Dare I say, waiting at 8 o'clock to answer the phone, which now they don't to ring up to make an appointment. That doesn't happen now. But somewhere there is communication needed. And I think this is possibly wider than just Harrow, but it's to make it clear that it's the new normal. It's not what it was. Thank you.
Thank you, Genevieve. Thank you. Would you like to come in?
Yes, thank you very much. So, Julian, I think you're absolutely right, and I think that using phrases like business as usual is not actually helping people understand what's going on at all. I think it's something that we've got into that phraseology in the NHS in some ways. There aren't words to describe really what we're going through, to be honest with you. So we're probably not choosing the right ones, but I think we also have to recognise that alongside all of the things that have gone on, that as people have mentioned, people would prefer to go back to a more face-to-face model. As well as that, we have developed new skills and tools that for some patients suit them very well. And we, you know, and actually everybody has had to learn new tips and tricks during this period. So certainly the way we deliver healthcare has been revolutionised by COVID, for good or ill. But many of our patients actually have discovered that electronic prescriptions work very well, that online consultations can work well in their place. But I think that you're right. I wouldn't want to completely go back to how everything was, because to be honest with you, I have never run to time in my entire life as a GP. And the idea that at this point I would have people waiting 40, 45 minutes potentially to see me in my waiting room, with the fear that I would have that they potentially could be sitting next to somebody who's more unwell than them and catch something. Actually, that does not fill me with a great deal of excitement. What I do want to do is I do want to see people who I think I need to see, or they think they need to see. And I think that Lisa's absolutely right when she says if people think that they need to be seen, they should have that honest conversation with the team and see whether that's possible or not. But we have got a very stretched workforce trying to achieve an awful lot, and through that we do need to continue to use our new tools so that we can do that in an effective way. That is something that Simon and the hospital are doing. It is also something that the community and mental health services are doing. And I think the truth is, all of these techniques have got their place, and it depends on the issue and it depends on the person. And that's the bit we have to negotiate to get right.
Thank you. Thank you, everyone. Can the subcommittee note the update, please?
Noted.
Noted, thank you. Okay, we move on to next item, which is system response to Health Watch reports on GP and primary care access. It's all in hand in hand. Please may the report be presented in brief. Thank you.
Good evening. Thank you, everybody, for inviting us along this evening. I think the last conversation has really taken away half my presentation, which is great for me. So what I will do is try and skip through some key points sort of fairly quite quickly. Hopefully my sharing's worked. The role, just to summarise, the role of Healthwatch is to gather intelligence and to check and challenge service delivery and to identify where services need to change. That is our role, and we are only as good as the voices of the people that we hear. Over the past year, the issue of access to general practices has been around for some time. There's nothing new. COVID has just exacerbated it. Healthwatch did a report back in 2017, and a lot of the issues, as Councillor mentioned earlier, were around in 2017, but I think COVID has just made it worse. So I think there is, as we've recognised this evening, a general awareness that the issues need to be addressed. But what I would say is we do, as a Healthwatch, recognise how hard everyone is working, and you know it's a fine balance from a Healthwatch to raise the concerns that we're having, balancing that against how hard we know everyone in the profession is actually working. But we balance that with the fact that, you know, patients do have the right to access services, and if there are issues, we're only doing our role to raise them. In April, we shared our quarterly trend reports with the committee, and I think beyond that, what I would say as a general rule with all the feedback Healthwatch here is people tend to come to us when they've got something to moan about. There are a lot of patients that are probably very happy, but so please take the reports and everything we're going to talk about here in that vein. I mean, our quarterly trend reports were based on the views of 561 people. It doesn't make the views any less valid, but it does put it in perspective when you look at the whole population of Harrow. We are a small team, so we try to reach as widely as we can. We try to engage with the patient participation groups, but you know, we're only as good as the voices and the amount of information that we hear. The one thing I would like to be really clear on is that of all the comments we get, they rarely relate to the quality of care that people receive. The issues tend to really just be around access to services. So I think it's important that we remember that. If I just move to my next slide, The key points that we did 2 reports this year. One was about GP and dental access, and our second was about mental well-being. So I'm going to concentrate initially on the GP and dental access report. And what came out of this was that people are, you've got the slide there, so I won't go through all the details, but generally, broadly, people are satisfied with the service. I think it's quite interesting to see that the overall sentiment was 60% positive. The accessibility on appointment bookings has improved in the final quarter, although the positive feedback still remains low at 32%. We have certain areas where we have more concerns that we hear from. So the Health Alliance Primary Care Network appears to have a particularly set of negative comments against it. 92% of the feedback is negative on that. But balancing that, we have surgeries like Bacon Lane, GP Direct and Mollison Way, where we receive a notable volume of really positive feedback. But there are others where we receive negative feedback. The ability to obtain timely appointments, which we've just been talking about, is a problem for many, with the congested phone lines and waits of days or more to see a clinician, and choice also appears to be an issue. I think Julian mentioned a really good point, and I think it's something that came out of the meeting that was held last week with both Lisa and Genevieve, is that I think there is a need for more clarity and education around what is available. I think in general, a lot of the concerns we hear are from people that don't understand the system. We find each of the GP systems traditionally deliver the messages in their own way. I mean, there are times in the past I've had to ring Genevieve, who's been fantastic, when I've heard this about one GP surgery, what's the truth? And she's clarified it, but there's a real, I think, need to clarify communication more, to have more consistency for patients, because they need to know what is available to them. And I think we have to remember, not everybody will go to a website. A lot of people, their first point of call is a phone. And I think if we tackle those barriers, I think the number of concerns and frustrations will probably reduce. But these are things that are all well known and recognised. Some of the key issues, as I've just said, it was from our report, were the GP telephone systems and booking systems, which we've talked about. There is an increasing concern about the commissioning of dental care and how it's not meeting demand. This is much wider than Harrow as well, and it is something that's being picked up at a national level by Health Watch England. We are repeatedly hearing stories of people either not getting appointments on the NHS, but if they pay privately, they can get an appointment for the same treatment. So these are things that really concern us. I think our report clearly identified that the Black, Asian, minority ethnic communities are disproportionately affected just in the way they access services, and also those with language, mental health or learning disabilities. What we did at the end of our report is we made some recommendations which were shared with the CCG, and in essence they were for the CCG to work more closely with the primary care networks and GP surgeries around the issues we've talked about. We recommended that NHS England looks at how the commissioning of dental services is looked at, and we recommended that the primary care networks, GP practices and dental surgeries work more collaboratively. Can't get my words out, it's late and ready for my dinner. Work more collaboratively with the Black, Asian and minority ethnic communities, those people that we are, I think the term I'm hearing these days, which is sad but a really good term, is the underserved people, those that aren't getting access for whatever reason. And also for the CCG to work with the primary care networks and the GP surgeries around access through language and barriers. We have had, I have to say, a fantastic response from Lisa and Genevieve to the concerns that we've raised, and they've already picked up and run with a number of these. The team, the CCG executive team, have already started talking to the GP surgeries about the concerns that have been raised and looking to how they can improve the access. I know that it's been picked up at the GP forums, and again, I know these are a 2-weekly thing, and they're also looking at how extended GP arrangements can be made to support some of the issues that patients are facing. I think Lisa and Genevieve may respond to this shortly. Some particular concerns we had related to the Stanmore Medical Centre, and I know the executive team have met with Stanmore and a plan of action has been put into place. It's too early yet to address how effective that plan has been, but certainly they've been very proactive, and I believe Stanmore and the PPG are working with Stanmore as well. We raised concerns regarding the PIM Medical Centre in our Q4 reporting, and I know a meeting was due to take place on the 2nd of June from that, so maybe we can get an update this evening. And also we've raised concerns about the Health Alliance PCN, and again, the CCG have gone out and reached out to that group. So I think they've been very positive in being proactive in actually looking to address what these issues are. With regards to the other areas, NHS England don't seem to really recognise there is a problem with dental provision. They keep claiming it's fine. So, but that's a national issue. So, with our small team, we're not progressing that locally. We are doing some work with dental practices and raising awareness about services and what is available. But the bigger issue is being tackled at a national level. And CQC, their response to our report was that they're just monitoring the activity that we've got. Before I go to the mental wellbeing report, I didn't know whether Lisa or Genevieve wanted to make any additional comment to the report. Or to the slides, sorry, not the report.
Just to say thank you for the report. This intelligence is really useful for us working with our practices. I think we have fed back a lot of the themes that we're hearing, and Marie, you've confirmed the action that we are taking. We have had the meeting with the PIM Medical Centre now. I know that particular practice was so heavily involved in the vaccination programme, the lead GPs and the practice managers, and they absolutely recognise that that maybe some of the backup based business would have been affected by that, but they are back in their practice now and working through with their patient groups some of the feedback that's come through here. But we continue to take this very seriously and work with the issues that you bring up.
I probably would just
thank you. Yeah.
Thank you. Yeah, I would probably just add that as Lisa said, I do think, you know, having the opportunity for you to highlight these issues, I mean, it does help direct our focus in those conversations. I'm just going to be honest, I always feel slightly anxious when I hear certain practices being kind of like picked out for areas of concern or praise, to be honest with you, because I always recognise that everybody can have a good or difficult experience in every practice in Harrow, and I know that although you haven't mentioned my own practice tonight, my practice is certainly not perfect, and you know, I just feel that everybody's trying to do their absolute best. It's just that sometimes it doesn't quite hit the mark, and as you said earlier, Marie, people tend to contact you more when there is an issue than when there isn't. So it's lovely to hear some of the really positive things, but I think that when we hear things that could improve, it's really important that we take that as a general comment on general practice in the main and not about a particular practice. That's how I take it anyway.
Thank you, Genevieve. Would you like to come back, Marie?
Yes, there was just the other report I was asked to just mention briefly this evening was our report that we produced in April, which was around the mental wellbeing of residents of Harrow. Obviously, we all know how much people are impacted by the pandemic and the lives we've all been living for far too long. So rather than trying to focus on one particular area, which was no way we could do with our resources, we just undertook a report that did really just to try and get a snapshot about how people were feeling. I have to be honest, I don't think the report identified anything that everybody sitting around this table wouldn't know, particularly Tanya with the work that she does. But just the key things that came out of it really were accessing of hours out of our services was cited as an issue, along with digital exclusion. Stress, worry and anxiety were cited as the key areas of concern as a result of the isolation, demanding workloads, the risk of infection, poverty, job security, and I'm sure there's more we could add to that. The view generally that we received back was that the easing of restrictions would certainly help people and improve by taking away an element of that isolation. The longer term impact places a greater reliance on support services being available and people being aware of where they can actually get that support. That was something that came through very strongly. and this relates to both the local community support teams, the GPs, the voluntary sector, and through CNWL. All of which who care for a range of physical and mental health needs. The key bit for me that came out of the report was the need for greater communication of the support that is available, and also to the need to have the need to see that the commissioning of future services is there and ready for the increased demand that we know is coming our way. Now, I have got a slight update of a slide from CNWL, but I'm almost probably going to just hand over to Tanya, if that's okay, as you're here, Tanya.
That's absolutely fine. Can you everybody hear me? So I've got a bit of a cough. I mean, obviously, as we all know, and expected really, referrals into mental health services have increased exponentially since COVID, particularly when lockdown eased, and certainly our referrals into some services gone up by at least 50%. Obviously, things like domestic violence, safeguarding issues, financial stresses, relationship breakdown, etc., have been the cause for lots of these. And then obviously we've also got those people with severe and enduring mental health issues, which has been a problem. When COVID first sort of hit Harrow, I suppose, we did actually increase our community services from 5 days a week to 7 days a week to actually try and keep our service users out of our inpatient services. But actually it was felt after reviewing that after about 6 months that wasn't really necessary. And so we did actually reduce back to 5 day a week working again within our community hubs because they just weren't being used. However, we always continue to have our face-to-face appointments and continue to do that, and we do virtual appointments as well. And IAP services have continued to do both throughout the whole of the pandemic and continue to do that now. As far as our medication clinics are concerned, we managed to keep those going as well. We wanted to keep everybody as well as we possibly could through the pandemic, and that's continued. At the moment, we are increasing our face-to-face services as well. Some service users obviously still don't want to come into services, but we are encouraging them to, because we'll often provide a better service and intervention if we do get people to come in. We've always continued to go out to their homes as well. Other things that we've been able to do actually since lockdown, we obviously did transform our services in September and align them to the primary care networks, but we've also had quite a lot of investment from NHSE, which was previously planned. We've managed to increase our staffing levels within our community and our acute services, and actually our targets that we need to meet for community services have also been kept. So referrals that come in, we do manage to see our non-urgent referrals within the 28-day time frame, and our urgent and emergency referrals have also been seen within the community. So considering the increasing referrals, we've done reasonably well. We've had a lot of investment as well into our third sector organisations. We've managed to get CAB services on site in our acute hospital, and we've also managed to get them doing clinics within our community services. We've increased our social prescribers over this period of time, hopefully to reduce the social isolation. And we've got the Red Cross also working in our A&E departments, doing their best to keep the complex patients that are regular attendees into A&E out. And we've also set up a crisis support service, which is 7 days a week, which is actually moving in July into our Bentley House site. We've got new monies coming as well, and we're hopefully, well, we start an older adult home treatment team as of September, which is a great addition to our services. So that will be keeping our older adults that can remain in their homes in the community when they're in crisis, and hopefully not having to go into a hospital setting. And we've had investment, as I said, in the community services home treatment team and with first response. We've also soon to come some link workers with our primary care network. So there'll be a link worker that's split between the PCNs and our CMHTs, which will be great to actually help bridge the gap between primary and secondary care. I suppose the other thing to mention, which has already been mentioned more as well, is we have set up the mental health work stream. That's something that started again in January, and that's everybody that's working and providing services for the mental health sector coming together on a monthly basis, looking at their priorities and working together to meet them. So lots going on. It's a very busy time, and also, and it's great to have this feedback. And it's, you know, it's obviously we're expecting things to become worse before they get better, I suppose, as far as mental health is concerned. COVID is going to have a very long-term impact, particularly on mental health. And we've also got to think of the impact of long COVID as well, the psychological impact of that. So we are working, and we do have our IAP services sitting with the long COVID clinics too. We do have our IOP services, and we would urge people to actually refer themselves to that. We do still have capacity in those services, and it's really, I think, key if we can make sure people, when they are feeling distressed, do link in themselves as quickly as possible and don't allow themselves to become lower and lower or more and more anxious. So that's where we are, really. So onward and upward, lots to do, but managing reasonably well.
Thank you.
And my last slide really is just a summary of what we've just said there, that the issues are being addressed. So I would just like to say thank you for allowing us the time. I'm sorry if that went on a little bit too long, but if you have any questions, please don't hesitate to contact me. Thank you.
Okay, before I ask questions, I suppose everyone knows England scored 1 goal. So hopefully we are winning. Okay, thank you for the update. And would you like to ask a question, anyone? Oh, Councillor Christine Robson.
Thank you, Chair. Is it all right for me to ask a question? Yeah, it is good. It's more of a comment in a way. I mean, thank you, Tanya, for your presentation. It's a long time since I retired from CAMS now, I realise. It's getting on all the time. But my comment, I think, is going to be something that stretches back into history, but sadly, perhaps also into the future. Your presentation was about adult mental health services, was it? Because that wasn't clear. And it's, you know, I am just going to do my usual bit, which I've done for donkey's years, which is you don't need to give me an update on how children are, but children also have mental health services. And it would be, I think it's extremely important looking at the range of priorities that we have and knowing that loading stuff into the earlier part of anybody's lifespan is going to increase their outcomes in old age. I just thought it might have been helpful if it could have been made clear that you were making a presentation at this point about the situation for adult services for mental health, and you weren't going to say anything about children. It's okay.
Apologies, I think it's with me because it was the Health Watch report that Tanya was responding to, and yes, our Health Watch report was based around adults. So apologies if it's confusing. And poor Tanya, I've just put her on the spot this evening, so I take the blame for that. But yeah, our report was geared at adults.
So should I have a go at you as well then, Marie?
Oh, you can try, Christine, but hey.
It's my usual thing, which is waving a flag for children.
Because no, you're absolutely right, but we are a very small team, very limited resource. We put the survey out there for everyone. It wasn't particularly targeted just at adults, but obviously we have to react.
They're the people who turn up, and they're part of your people who come and complain and say that they're finding life very difficult. I do understand that.
No, we do desperately try and reach out to younger people. We're getting there slowly.
Hi, Tanya. Sorry, you want to come back?
I can respond briefly in relation to all the changes or what's going on for young people and in around COVID. It isn't the service that I manage, but CNWL do.
No, I know. Yeah, and in fact, Tanya, I kind of know, and it may not be the remit of this this committee to know. But I was just nitpicking a bit about how you titled your presentation. That was all. Thank you so much.
Okay. Simon Crawford, would you like to come back?
I was just going to make the comment that in relation to children's mental health services, nationally they've announced today £40 million investment in children's mental health services, recognising the fact that children have been adversely affected as part of COVID, and historically it's been an issue, and exactly the thing you say, Christine, the importance of children getting timely access. Clearly it'll take a bit of time for that money to filter through and be operationally available in the front line for services, but at least it's a step in the right direction and has been recognised nationally.
And that's it's historically important, isn't it, Simon? Because, you know, I've spent a long time banging this drum. So thank you very much, and thank you, Tanya.
Thank you, Simon. Tanya, do you want to come back?
I just was going to say that actually CNWL and the rest of North West London have started a transformation project for young people's services. So it is actually already underway, and we're very much looking forward to some of that investment.
And so am I. Thank you very much.
Thank you. Right, Veena, you've been waiting for long, but Veena, would you like to ask a question? Hello.
Yeah, thank you, Chair. Lovely slides and very informative. My question is, the survey you carried out, was it all sort of like, or was it sort of through phone as well? Because there are certain sections of community or people do not have access to computers, especially I know in my ward, some people are not really, either they do not have internet or they're not computer literate. So how would you have reached that sort of community or residents?
Yeah, what we, it's a really good point to raise. Our survey was electronically, but what we did do, we have been doing some work with the Romanian and Somalian groups, and our outreach manager actually joined those groups and worked with them to actually go through. So there were a couple of sort of outreach sessions based around what the survey asked, which then we fed into the survey in that vein. But your point's absolutely valid. You know, we continue to try and improve the groups that we can reach, but it's hard. It's very hard because we're a very small team, and trying to open doors that aren't already open is also quite different. So I would be more than happy if you can help us in any way to work with you. That would be fantastic.
No, that will be very great. Yeah, great, and grateful for your presentation. And maybe with the councillors' help, maybe we can reach different sections of the community and different age group as well. Yeah.
Yes, that would be
okay, lovely. Thank you very much.
Thank you. Can I ask a question, please? What is being done to ensure better access to care as we recover from the pandemic? What practices that were introduced during the pandemic will remain? Anyone? Hello? Mari, are you muted? Genevieve, would you like to come back?
Do you mean in relation to the mental health aspect or in relation to the general practice aspect of Marie's report?
General practice, yeah.
So I think, as I was saying earlier, I think there will be things that we keep. So I think that we will continue to want to use things like electronic prescriptions. I think that they actually are safer, better for the patient, less, much easier to make sure we're providing the right medication, and that we can see more clearly whether people have picked it up or not. So electronic prescriptions, I think that will definitely remain. I think we will continue to see online consultations being used because that was the direction of travel even before COVID. So that was always the plan. The way that we're using them and the amount that we're using them, I would hopefully see that diminish, and it would start to feel more like a choice for patients, that they could use them if it's the right approach for them, rather than always having to be that way. I think telephone triage actually will continue, because actually getting the person to see the right pathway at the first time is actually quite attractive for many patients. They do sometimes end up going a bit around the houses because they don't know the right pathway to choose, and talking to a doctor or a clinician about their symptoms can sometimes mean that instead we'll go down an emergency pathway or go down an urgent cancer pathway. And if people were waiting long periods of time to be seen, I think that would probably be to their detriment. And I hope we keep the efficiency that we've had to achieve as part of COVID, because I do think that for people, when they do turn up, to know that when we say an appointment time, we're very likely to mean that appointment time. I think that's actually been been very nice. I had to go for a hospital appointment a few months ago, and something that I knew would normally have taken me hours, I was literally in and out. And I actually thought to myself, my goodness, this could be amazing. I'm very sorry we had to have COVID to achieve that, but it was actually really fantastic. So you know, there's lots of positives to be gained, but I think that what we want to bring back is that feeling that we are still there for our communities, that we are, you know, we have the doors open, but it doesn't feel like we have the doors open. And I think that's the bit that we need to kind of like work on from a general practice perspective.
Okay. Would Simon or Tanya would like to say something?
Yeah, I'm very happy to comment. I mean, as far as mental health, I think there's been quite a lot learned during the COVID, and we certainly don't want to lose it. And I think similarly to Genevieve, assessments and triage can be done online, and we can often see more people because we can see people online if that's what they would like. Certainly, IAP services have found that, and our outcomes have not got worse because it's been digitally done. I think the other things that we found really helpful are meetings like this. Actually, you can, you know, multidisciplinary team meetings, you can pull people together to actually have a really good multidisciplinary discussion about an inpatient, for example. You can bring in the community, families are able to join those meetings, social workers, all people that are all disciplines that are involved with that individual can very easily be accessed to come together to have some complex discussions, which I think we really find incredibly invaluable. And group therapies as well, that's been something else that's been found to be really great. People will attend appointments more frequently if it's via a dial-in. So I think there have been some positives that have come through this, and we do need to, you know, we really do need to hold on to them.
Thank you. Simon?
Yeah, more of the same, really. I think in terms of virtual clinics and triaging, etc., some of that's here to stay. Clearly we need to get the balance right, and for some patients, and especially children, I think face-to-face is particularly important in terms of assessment. But again, some of our operating practices have improved through the use of Teams and those sorts of things. But equally, some of the new processes and procedures we put in around things like same-day emergency care, referrals into specialist services through A&E, and some of the sort of moves around some of our services on sites and between sites. Some of those we're unlikely to move back in the in completeness in the fullness of time, because they've given us better efficiency, a better location, a better co-location of services as well. But when we're in a position to confirm, definitely we might well need to come back and share with you what those plans are.
Okay. Harrow has one of the highest levels of tooth decay in young children in Harrow. How is this being addressed? Is access to dental services one of the factors contributing to the poor oral health in children? Thank you.
You want me to start on that one? Yes. Yeah. So yes, we do have appalling teeth in young children, and some of the things that we've been looking at over the last couple of years has been raising awareness around toothbrushing for very young children. So making sure that parents know when to brush teeth. We were quite surprised. We did a little survey on when would you start brushing your child's teeth, is the question that we asked. And we left it open for what people could say. And the right answer is as soon as the teeth start erupting, or possibly even before, to get them used to the idea of a toothbrush in their mouth. But we did get people saying when they get toothache, or if they've got all of their teeth. It was when they start school. It was a real strange array of answers. So there's obviously a lack of knowledge within some parents. So we've been working with health visitors around making sure that they're getting those messages across. And we've been distributing through the health visitors oral health packs with different toothbrushes available for the different age groups. So it comes with the right sort of toothpaste and the right sort of toothbrush for the age of their child. And that carries on with the school nurses so that they can talk about oral health in primary school and in secondary school, because it's really important that as kids get older, that they don't suddenly stop brushing their teeth when they get older. I don't know, having grown up with a brother who went through that teenage boy thing of suddenly being feared of water. I'm sure that toothbrushing probably was not high on his agenda either. But I think it's one of, you know, it's an important thing that we don't think of it as just being somebody else's business. It should be part of what we, you know, any contact with people, you know, around their children should talk about this. So it's about bottle feeding and not using sweetened juices. It's about what we do in schools. We put in schools with lots of extra water fountains the year before last to encourage schools to go water only, so that we didn't have kids bringing in fizzy drinks. We've promoted Fizz-Free February for the last few years. I'll admit that this year we didn't do very much on Fizz-Free February because we slightly focused on the pandemic. But we will be back to it next year. And it's all of those things. But one of the things that Marie's report highlighted was about about dental services, not just community dental services, but NHS dental services in general, and when children should go to see the dentist. And it's very, very difficult when you've got small children to get that first appointment. And we definitely need to get children in to see the dentist and to see them young before they start going with toothache. Because if your first experience of going to the dentist is when you have to have a filling or have a tooth pulled, then that actually ruins your idea of what it's like to go to a dentist. Your dentist should be somebody who helps you stay healthy and not need to have those things happening. Yeah, so that I think is really, really vital, and it has been highlighted, you know, in a number of surveys that is an issue, and we've also raised it from a public health point of view with the dental commissioners at Department of Health and NHS England.
Thank you, Carol. Last question: how can local systems leaders use the Health Watch intelligence to plan local mental health support post-pandemic? Will there need to be a shift in emphasis or priorities as consequences of the pandemic? Thank you. Anyone?
I think from a Health Watch perspective, I think where we can support and help is through communication. I mean, we have a fairly strong network. We have bi-monthly newsletters. We have a website. We can send things out. We've got a strong team of volunteers that are fantastic. So yeah, I think any messaging we can certainly support with, and we're happy to try and do outreach with specific groups to deliver certain messages. So I think from our perspective, whilst it doesn't appear a lot within, you know, the resources that we've got, we're certainly happy to support where we can with that.
Okay, Tanya, would you like to come in? You're muted. Can't hear you.
Sorry, I mean, just can you hear me now? Yeah.
Yeah. No,
just to add, as I said earlier, we do now have this mental health and wellbeing work stream, and one of of the themes of that work stream is around prevention, and so we're working very closely with public health. That's actually part of that as well, looking at how we can start preventing people to enter the pathway in the first place. So there's lots of work that's going on there with our IAP services as well. And I agree, it very much is about getting the message out there, making sure we are using our local population and their local links, their friendships, their families, etc., to keep people well.
Thank you. Sorry, the last question, if Councillor Marika is still there. Councillor Marika, are you there, or she's in the other meeting? I think we'll send the questions.
Quickly, I'll ask that question again. Because mental health is very passionate to me. I think mental health has to be, as you all spoke in the NHS, all the trust, because I work for the two trusts, Hertfordshire as well as CNWL, and I think as policy-wise, I think the staff has to be taking responsibility. The team leaders in the units has to take responsibility of the well-being of the mental health, because there is certain staff doesn't have empathy and care. They're just there for sake of a job. So it has to be looked at, and praisals has to come on to the staff members, because mental health in COVID side, the youth has been attacked very badly in Hertfordshire, my own experience. So I'm not going to ask you a question. I'm telling the hierarchies, the doctors and the senior colleagues in the NHS Trust, this has to happen. In my experience working in mental health from 1995 with my son born, and till now I still work. And I know exactly there's a lot of things happening. So I would love to speak to Dr. Small privately and certain things. And I think that has to be implemented in my passionate. That is why I declared my interest before I joined the meeting. So I will write emails. Please do send me some reply. I have to go again. Thank you. Please, that's my last question for the.
Okay, thank you. Okay, can the subcommittee note the update, please? Noted, thank you. Now, Mount Vernon Cancer Center review update. We would now have a presentation from representatives of NHS England and NHS Improvement. Would Ruth Derrett or Jesime Kinghorn introduce the report in brief, please?
Yes, thank you, Chair. Ruth unfortunately can't be here tonight, but you've had the latest update that I believe has been circulated to members, so I will keep it incredibly brief. Sure. Just to say we are making progress on the plans for Mount Vernon. You'll be aware that they involve relocating onto an acute hospital site. The site that's been selected as the preferred one is Watford, for various reasons that we've discussed before. I think what's worth noting is that we are looking at plans to see if we can expand the chemotherapy provision at Northwick Park. Or Northwest London ICS. I know colleagues are on the call from there, that we're working to support them in looking at how they can improve access for people living in Northwest London. And so that's one potentially really good piece of news for people living in Harrow, many of whom, or most of whom, go to Mount Vernon at Northwood at the moment for their chemotherapy. We're looking to see if more can be done at Northwick Park. We've had recently an initial assurance meeting with NHS England, and that's a process that we will have to go through before we get to public consultation, and gives us an indication of whether we're following the right process and whether we've got the right kind of business case together. And that's been very positive. This week we are meeting with the Clinical Senate, and that's an external independent view on whether our proposals for changes to services are clinically sound. Hopefully that will all go very well. I've been interviewing patients over the last couple of weeks to build up our portfolio of patient stories. And we've got some work streams that we're working on at the moment around some of the themes that have come up from patients. Care closer to home is one of those, but there are also others. For example, patient records comes up quite a lot. We've had really good engagement from the Health Watch representatives for Harrow, and we had recently a patient reference group meeting, which Harrow was actually the best represented area. That was really encouraging, and we're having some really good input into the programme. So rather than talk through the detail, because I think we discussed it previously before, it's probably easier if I take questions, unless Simon or somebody else wants to add something from a North West London ICS perspective.
Okay, Simon Crawford, can I invite you? Yeah.
Yep, happy to comment. So yes, we've been working jointly with Hillingdon, actually, in terms of Hillingdon Hospital NHS Trust, in terms of developing the case for further investment and expansion of the chemotherapy unit on the Northwick Park site. It's about 1,000 Harrow patients at any one time or any given year are affected by the change, and certainly in terms of the travel analysis that's been undertaken, it would be easier for them to reach the Northwick Park site than certainly to travel to Watford. And in many instances, it'd be closer than Mount Vernon as well for some of those. The impact is for the equivalent of about 3 chairs. So we currently have provision for 8 chairs of chemo at the Northwick Park site. So it expand it from 8 to 11. So we're looking at the expansion of that, and also the increase in the staffing and the pharmacy and the aseptic unit, and we've got all that sort of potential capacity in place and being able to expand it. And of course we will work with Hillingdon as well in terms of jointly doing this, because it's a similar impact, I think, in terms of the Hillingdon Hospital site, where they would look to expand by the equivalent of about 3 chairs. So we'll be looking at doing that jointly in terms of taking it forward. So in many respects it would provide and a lot of those patients of those patients have access at Mount Vernon currently. So in terms of their first engagement after radiotherapy onto chemo, etc. So in many senses, it would be a continuity of that care. So we're confident that we can flex up the capacity on the Northwick Park site, and certainly in terms of the finances, in terms of the transfer of income that would have gone to Mount Vernon for those chemotherapy patients would transfer to the Northwick Park site, so it's financially sustainable for us. Happy to take any questions.
Thank you. Councillor Leslie Lewinson.
Thank you, Chair. Thank you, Jessamine, for that. I read through the report that you presented, and what I wanted to ask was the possible reasons for Harrow's low uptake of radiotherapy services. I couldn't really sort of think what could be the reasons for that, for radiotherapy services.
Yeah, we're doing quite a lot of work across the whole of the Mount Vernon catchment area to understand more about the radiotherapy uptake. I'm just looking at the briefing. I think you may be referring to a different one than the one I thought had gone out, so apologies. I don't have the numbers in front of me, but we do know that there are some areas that are quite low in terms of radiotherapy uptake. So we're doing quite a big piece of work in Luton at the moment, because that's an area where the radiotherapy uptake is low and outcomes are particularly poor as well, and we're trying to understand that and then translating some of the learning across, and we'll be testing that in different areas. But I can certainly come back to you with more detail on the radiotherapy uptake. I think I'd want to take advice from the Cancer Alliance before responding, get some clinical input.
Simon?
Yeah, I was just going to say, I think the analysis, I haven't seen what you particularly are referring to, Councillor Lewinson, but what I would say is that most of the analysis has been about the patients that access the Mount Vernon site. Of course, not all Harrow patients will access Mount Vernon necessarily for their radiotherapy. Some of them will go down to Imperial as well. So I'm not sure whether that is a phenomenon of low uptake of radiotherapy per se. It may just be that not all of it's going to Mount Vernon, and therefore it looks disproportionately different for some of the other populations being compared with.
Okay, thank you.
Thank you. Councillor Michael Borio.
Thank you, Chair, and also thank you, Jasmine and Simon, for the really useful update on this. I just wanted to come back to the point that you raised about extending the chemotherapy services at Norfolk Park Hospital. Obviously, this would be very welcome to residents in both Harrow and Brent who are using the hospital. Are you able to give any more information about when this is likely to become available? Thank you.
So in terms of the expansion of the service, it'll dependent on the success or otherwise of the business case for the broader business case for the changes around the Mount Vernon site, because there's no intention to materially change the referral lines before that change. And Jessica may know better than me, but I suspect we're at least 2 or 3 years away from that major service change taking place, because that capital investment needs to take place on the Watford site before we've seen that material change taking place.
Yes, thank you. If I just add 2 things onto that. One of them is that we will need to go out to public consultation on the proposals, because, as Sam says, it is a material change. We can't do that until we have got what is termed a route to capital. So we need to not necessarily have the money in our pocket for the new building, but we need to know where it's going to come from. We're not in that position at the moment. We don't know. We're not on a hospital scheme. We're not one of the lists that's been announced. So we are having really positive discussions around that, but we won't be able to go out to consultation until that's finalised. As soon as we can go out to consultation, assuming that the consultation goes smoothly and the plans are broadly supported, albeit, you know, through consultation you expect there to be a few tweaks that come through, we would be able to then look at developing a timeline. And I think the programme team are taking quite a pragmatic approach, and there's no reason why some of the work that's going to be done outside of the main hospital couldn't start sooner than the building time it will take to build the new cancer centre. Certainly with the chemotherapy chairs going into Hillingdon, they don't currently have a chemotherapy unit as such, that will be incorporated into their hospital building programme, but we are looking to see where the changes will benefit patients locally sooner and we can deliver it sooner. We will try and do that, but it's all dependent on completing a public consultation, which will begin once we've got the capital funding agreed. The earliest we've got on the plan at the moment for public consultation is October, but realistically, if we haven't heard that we have secure capital funding before September, then it's just going to delay public consultation. From a personal point of view, I would like to be out to consultation before January. I think if we don't make it to public consultation in January, we're probably not going to start a consultation until June, because it starts to overlap with the pre-election period, and it covers such a broad area. There will be places where there'll be local elections that we don't want to be holding a consultation during that time.
No, thank you both. That's useful to know. Thank you.
Thank you. Veena, would you like to ask your question?
Thank you, Chair. I just wanted to ask about the Norfolk Park. The chemotherapy will be sort of delivered more at Norfolk Park. Have they got the capacity? They are so stretched. Will new staff be recruited? And where will be this service provided in Norfolk Park? Have you found a location, or is it at the existing location and those people would be going?
So a couple of years. So a couple of years ago, we did establish a new chemotherapy inpatient unit, Drake Ward, in the old near the old A&E at Northwick Park, and alongside that is the chemotherapy day unit, where it's got the chairs and the sitting area and the reception and alongside there, and there is space to expand outside of that area. Those as I said, there's 8 chairs currently. There's a corridor, or there's a gap between there and the main outpatients where we could expand outwards, and so there's some minor capital works required to expand the footprint outside of that, so it would increase the existing sort of day unit from the 8 chairs to the 11. So it is already a pretty modern fit unit, because it was only established about 3 to 4 years ago when we moved Drake Ward and that unit onto the site. And in terms of, we already have plans to expand our aseptic manufacturing unit for the chemo drugs on the site. We do have MHRA accreditation for that manufacturing unit at the moment, and so we were expanding that unit and planning on expanding that unit, and are well advanced in terms of the capital plans, and we have secured the capital funding for that previously, so we are in a reasonable position in terms of being able to increase capacity on the site.
Thank you, that was very helpful. One more question. At Mount Vernon, I forgot the name. Is it Jackson? Which Jackson is it? There's a center there. And what will happen to that name? Because I think, was it through fundraising or something? So that's one question I was asked. And I think it's about the radiotherapy unit, not the scanner. It's the scanner thing, I think. Is it gonna move? So those two questions, please.
Okay, I can take both of those. So both of the services are within the scope of the review. So we will need the scanning services, and we will need the patient support and information services at the new cancer centre. Just by way of example, Paul Strickland Scanner Centre, the chief executive of that organisation sits on the Mount Vernon Review Programme Board and is part of the decision making. They are their own organisation. They will have to make their own decision about moving, but their services are in the scope of the review, and we will need them on the new site. The Linda Jackson Centre, the same. I can't tell you about the name because it obviously belongs to a family who have made a lot of donations, and there will have to be some conversations about what the new centre is called, what happens to the Linda Jackson name, and we're not at that stage yet. But we understand that it's a very well loved service. One of the work streams that I've set up is a patient information and support work stream, so that patients can get involved in helping to decide what the future is. And Macmillan are supporting me in running that. It's a Linda Jackson Macmillan Centre, and they are supporting me in running those events with an open mind to what it might look like, but making sure that we capture those services and the value that they add to patients, and we can incorporate that into the new building. Some of the programme team have also started to think about how we can outreach that service. So at the moment, if you want to attend a Linda Jackson class or something, you go to the cancer centre, and we're starting to think, well, how can we provide a service that can be just as beneficial for people who live locally as it can for people who live in Bedford or in Ealing or in Hertford, and could we provide some sort of an outreach, particularly in this era of virtual engagement? Surely we must be able to come up with a new model that can provide added benefit for people. So again, it's really early days, but I think the important thing is, yes, there will be that type of a service. I got hold of a video of, we haven't put on our website yet, but of the UCLH Cancer Centre, their cancer centre in London, the patient information support service that they provide. And I've spoken to the Clatterbridge Cancer Centre as well. They provide a really thorough patient information and support service. So we want to learn from what's happening in other places and make sure that what we provide is really does what it needs to do for patients. I think a lot of people get confused because they go to a general hospital and they see a very small cancer patient information area. The main cancer centres tend to provide something much more holistic, and that's what we're looking at.
Lovely, thank you. That's all from me.
Thank you. Can the subcommittee note the report? Noted.
Noted, yes.
I would like to thank the NHS England and the NHS Improvement representatives for their time. You're more than welcome, to remain on this call for the remainder of the meeting. I appreciate you might have had a long day, so do feel free to leave if you prefer. The meeting will be recorded and will be available on the council website for you to watch if you wish. Thank you for coming. Thank you.
Thank you.
Thank you. We are on the last item now, which is update from North West London Joint Health Overview and Scrutiny Committee. So I can just read out the recommendations. Consider the update and provide any comments, issues that are to be raised through the JOSC by Harrow's representatives. Consider the issues raised at the JOSC meeting to inform its own consideration of the impact of COVID, the rollout of the vaccination program at the local level and local service recovery. Veena, would you like to add anything?
I think it's all covered, and
yeah,
I don't have any further comments to add.
Okay, we have new chair now, the councillor. Sorry,
Councillor
Councillor Ketan Sheth. So that's kind. Okay. Can the subcommittee note the update, please?
Noted.
Yeah, noted.
Last item, any other urgent business? I have not been notified of any urgent business. I would like to thank everyone for contributing to this meeting and attending this meeting. Thank you very much, and we would be continuing with virtual meetings, so we have more people coming and contributing. But thanks again and good night.
Thank you, Chair. Bye, everyone.
Bye. Bye.